Good afternoon. My name is Kristen Zarfas. I am a breast cancer specialist at Trinity Health of New England, most particularly known as St. Francis Hospital in Hartford. We have two other hospitals in Waterbury, St. Mary's, and also in Springfield, but I'm at Trinity Health of New England at St. Francis in Hartford. I am the medical director of the Women's Health Program, which is why I'm honored that James has asked me to come to be a guest of his today, because we're talking about women's health.
Yes, and I understand from some of the literature that you sent me that you're pulling back the veil. So what exactly do you mean when you say you're pulling back the veil?
Well, Jim, or James, we've known since the 1970s that all women have different risk factors for developing breast cancer. For example, women of Jewish Ashkenazic descent have a higher risk of having a mutation in two genes. Women who have a strong family history of breast cancer, regardless of ethnicity, are at an increased risk. And we've known since the 1970s that a disproportionate number of young Black women develop breast cancer before the age of 50. In fact, a third of Black women develop breast cancer before the age of 50, but no one has talked about this. There's been a veil around it, even though it was published, this data was published in 2002 in the journal Cancer. So today, post-COVID, when we know that people of color have a higher risk of developing COVID, I believe that no longer can we have the veil around the facts of breast cancer in young Black women, because they go underdiagnosed or undiagnosed to a later stage.
Now, is there a reason for this? Access to healthcare, or lack of access to healthcare, I should say. And I've been talking with my sisters about breast cancer, and it seems that Black women's breasts tend to be more dense, I think
Yes.
they said, or whatever. So can you talk about that a little bit, and how that kind of, you know, heeds the progress or prevents, further progress?
Yes, let's talk about breast density, and then I'll come back to why the reasons for this disparity. So when we're young, all women tend to have dense breasts. And dense breast means that on your mammogram or on your breast exam, your breasts are very firm on physical exam. On mammograms, the breast will look white. Now, breast cancers are white, so they are obscured. They're hidden if your breasts are dense. As we become older, breast tissue atrophies, dries up. With age, our breasts have a different texture, they're softer, and mammograms will tend to have more of a black background, which is good because a white cancer will stand out. So you're right, there are studies that show that Black women will tend to have more dense breast tissue just by definition. Some young women have breasts that aren't dense, and some older women might have dense breasts, but as a majority, younger women and Black women tend to have dense breast tissue. And that's not just your sister's observation. I actually have data of a study that shows that.
So why the disparities? Why is it that more Black women aren't getting the information that they need, or the health benefits that come from early detection and so forth?
Well, I think there are three factors we can go after that are very apparent. And then there's the second category, which I'd love to talk about if you want to, are called social determinants: access because of insurance, lack of insurance. But the three issues that we can go after, which is why you having this show is so important, is we need to educate women without any stigma or being toxic, and say, just know that you might develop breast cancer younger than you might have thought. And so educating women, and I have worked with one of your former guests, Sisters Journey,
Right.
who you've interviewed. Love
Yeah, they're
Don
a great
Bresky
group.
White. They're wonderful. And so we worked together a few years ago, reaching out to women at churches, diaper days, daycare centers, beauty salons, just to educate women, just to say, this is part of your health. Part of what I do as a medical director at the Women's Health Center is I'm into women's health, empowering women with the facts. And so whether you're Jewish and you should have genetic counseling, whether you're a young Black woman and you should be more aware, is part of what I like to do, which is why your show is great. That's the number one factor. There's a second factor. We need to educate providers. So can I give you an example that
Sure.
is so much more succinct and so much more articulate than I can ever be? I happened to be watching the PBS NewsHour at 7:35 p.m. on June 3rd, and I wish I had a snippet to bring to our discussion today. They were looking at women in Washington, D.C. with breast cancer. And sadly enough, unlike in New Haven and Hartford, where we have mammograms available for Black women of all ages, this part of D.C. didn't. So during this interview discussing a mobile mammogram machine, a lovely 32-year-old woman who had had bilateral mastectomies, that means she had to have both breasts removed, had chemotherapy, said this. She said, I didn't think I could have breast cancer this young. And when I went to my provider, I was told, quote, you're too young to have breast cancer. And I have heard this before, particularly since women I've learned to know through Sister's Journey. So these are the issues we need to help our women be educated, and we need to educate providers.
Go ahead.
Go ahead.
I was going to ask you how we are going about doing that, but go ahead and get to your third point, because I think you want to.
That's so important is the U.S. Preventive Task Force guidelines. So there are two sets of guidelines that tell physicians when to order screening mammograms. So there are two types of mammograms. One is screening. You don't have any symptoms. You're just having a mammogram. The other is diagnostic. So any young Black woman that comes in with a lump she finds, insurance, Medicare, or even free mammogram programs will pay for a mammogram or an ultrasound. But screening is where you're doing studies, mammograms, and ultrasounds if a woman's breasts are dense that your sisters talked about, to find cancers that are too small to feel. And right now, the U.S. Preventive Task Force guidelines say don't start mammograms until the age of 50, which ignores a third of Black women. And the American Cancer Society guidelines say start mammograms at age 40, 45, every other year, but they also are ignoring a large segment of the population of Black women.
Now, when you're just talking about breast cancer out in the different areas that you go, are you finding an educated public, or are you finding a public that's not very educated about breast cancer at all? I understand that, that young lady said she didn't realize she could get it so young. But what about the women who are, say, 50 and are well aware that that could be a problem? Are they taking proactive steps, or do you find that it's just isn't up here with them?
Well, I think let's break it down into two categories. I think most women who are in their 40s or 50s, they're physicians, nurse practitioners, APRNs, recommend mammograms, screening mammograms because of the guidelines. I think that most young women think that it's breast cancer, whether they're Black or of any ethnicity, thinks it's breast cancer is a disease of older women. And so I think not just most young Black women, but most women of all ethnicities, white, Asian, American Indian, aren't aware that they can develop breast cancer so young. I think there are also cultural mistrusts. I think there are cultural differences. Some people of different ethnicities have different, we might call it denial. It can't happen to me. I mean, I think we're seeing denial in America today where people don't think they can get COVID, and therefore they don't take the vaccination because they believe they can't get it. They can't develop COVID, and we're seeing the fallacy in that. I think when you sit down with women, regardless of what ethnicity the physician is or the patient, if you're sincere to them and say, look, I want to help you. I want to empower you with the facts to take care of yourself, whether it's a discussion about sleeping, exercise, diet, other things that I like to talk to patients about, informal discussions that are documented, evidence-based on how to empower women in their health. And so I believe that, to answer your question, there is an age difference in embracing the fact, but I think there, across ethnicities, women don't know they can develop breast cancer at young ages. It's just disproportionately higher, a third of Black women before the age of 50 compared to 22% of white women. And
What
so,
about what about mortality rates?
oh,
Are mortality rates higher amongst Black women?
they are. Their mortality rates are higher for a couple of reasons. First of all, we're not finding these cancers early enough. When I say these cancers, Black women will tend to have a higher proportion of breast cancers that don't respond to our hormones. The
Really?
term is called triple negative. And triple negative means some breast cancers will have receptors on the surface that respond to estrogen in your body. And there are pills that can target those receptors and turn them off. There are receptors for estrogen, drugs to turn those off. Progesterone, no drugs. And a third characteristic, and doctors love fancy names, but it's called HER2, HERNU2. But the key about HER2 is that there are drugs to target it. If a young or older woman has a tumor that has no receptors, we don't have any drugs that can target them. Let me back up and say this. We take a cancer out, and then we give medication that goes through the entire system to decrease the chance of any cancers that may be smoldering or hiding somewhere from them growing. And if you don't have a target on those cells that might be hiding, then you have to blast a woman with chemotherapy, and you don't have targeted therapy. So the triple negative tumors are more aggressive. Black women tend to have not just triple negative, but other characteristics that are more aggressive. So for my perspective, let's find those cancers early. So mortality is partly the type of cancer, but also 44%, almost a half of Black women develop cancer that's already, when they discover it's already advanced. So that's part of the answer to your question, and part of my wanting to educate not just women, but their providers. Keep in mind that these women can have cancer earlier. So let's start screening younger so we can decrease that disparity in mortality.
I have a question because I'm a little confused because many of these women are getting help through doctors. They are going to see doctors, some of them. How is it possible for a woman to have cancer and it's like more, it is, like you said, more than 50%, you know, by the time you get to it, it's too late. How is that possible if you're going to your physician on an annual basis, doing checkups and so forth? How is it possible for it to stay hidden that long and, you know, and take away pretty much all hope?
Well, you touched this, and your sisters raised the issue, and they educated you. If you have dense breasts, they're harder to find. So think of dense breast tissue as an insulation. So it's harder to find on physical examination.
But is there a test that can, is there a test that can show or weave through that dense, see through that dense density?
Yes. When women have mammograms, okay, but remember the guidelines say don't start until 45 or
Right.
50. When they have dense breast tissue identified on the mammogram, a screening ultrasound can find 7 out of 1,000 cancers that are otherwise missed on the mammogram, where the white dense tissue is obscuring the white cancer. So the key, you hit the nail on the head. The key is to do mammograms earlier. If a woman's breasts are dense, which you, as you pointed out, Black women have dense breasts, the screening ultrasound can find it when it's missed on mammogram, but we must be doing mammograms earlier.
Is there a correlation between the size of the breast and cancer? I mean, if a woman has smaller breasts, are they less at risk to get cancer?
Well, that's a logical question, isn't it? But there
Right.
isn't, it's a lot, if you have more breast tissue, but not necessarily. Many times if breasts are really large, they won't be dense. And so cancers will show up earlier. And if breasts are really small, they tend to be denser and compact. And so the mammogram is obscure. This state and many of your people, your audience who's listening in, have contributed to studies and the first legislation in the country to have screening ultrasounds done in dense breasts. But there's another issue we want to talk about after
Okay.
I've answered any questions, and that's doing breast self-examination. So when I went to medical school a while ago, I graduated in 1979, we encouraged women to do breast self-examination. And through the years, um, uh, the world of medicine has embraced only scientific studies that are done prospectively. Well, in America, again, regardless of an ethnicity, you're not going to take 1,000 women and tell them to never touch their breasts and another 1,000 women to examine them yearly and control for other factors. So the only prospective clinical trial was done in Shanghai and published in 2002 that said there's no evidence that doing breast self-examination saves lives. The study did say clearly you're less likely to have a mastectomy if you do self-exam because you're finding things earlier than they might show up by your found by your physician or provider and on mammogram. So we need to encourage women to know their breasts and do self-exams and not be afraid to come into a provider and say, look, I found something. And we're either going to be dismissed and said, like this woman on the PBS NewsHour, oh, you're too young, you don't have breast cancer. But you
Right.
see, that's educating providers, which is the second part of of the three strategies I think we need to support.
Well, actually, I'm working on a program with Yale with doctors in the infectious disease, the School of Medicine at Yale,
Yes.
and that's one of the things we have concentrated on is how physicians should talk to patients when they come in, what they should ask, how they should, they need to have a rapport so that the patient feels more comfortable discussing things such as breast cancer or whatever else they're there for. And so I agree with you. It is, we have to educate the provider also. So how are we doing here in Connecticut?
Well, James, how we're doing as far as educating, I've been fortunate that Trinity of New England is supporting taking the veil back. And part of that strategy is outreach, hiring an outreach worker. I'm glad to go out and talk to anybody who's willing to listen to me, as I did with Sisters Journey a few years ago. But also, Trinity has 92 hospitals in 22 states, and they're embracing Zoom discussions like this for their providers. I've reached out to people I know at Quinnipiac PA School, a physician at Quinnipiac Medical School, and they will be welcoming in the evidence-based talk that you've already reviewed to there. I've reached out to University of Connecticut Medical School to talk to the medical students there, and St. Joseph's has a nurse practitioner in PA school. I'm just one little person trying to spread the word. But I believe that providers just don't know these facts.
I was going to ask you because, I'm wondering how much of this is getting through to providers and physicians, and so forth. I know right now there is a big push to learn more about the issues in the Black community and getting access to health and so forth and so on. But I also know that, I'm old enough to have been around there. We've had these little pushes before. And it does seem to me that the providers play a huge role in getting people to the point where they're comfortable coming in and talking to them, because a lot of these people are low income. They don't have money. And I think a lot of that weighs on them when they go to see a doctor, because in a sense, they do have their hands out. So they don't think they're getting very good they don't think they're getting the whole story most of the times when they go to see a doctor. So what can we do to make it so women in all health matters feel comfortable, and women of all ethnicities, all income brackets feel comfortable going in and discussing their problems with doctors? And I'm wondering if one of the problems is we have too many male doctors and not enough female doctors and not enough doctors of color also. That's a problem, I know that.
Well, I think we, really good physician's assistants, nurse practitioners, and that addresses not enough doctors. But what we need is time. And time, you have to build trust. A woman who's scared, who's meeting somebody who feels she's on an assembly line, in the door, out the door, how can I get your trust if we don't have time together? And trust is a
Right.
5-letter word that's a key to exactly what you're talking about. Because I believe, even though there's studies, for example, I have a talk, I review the literature on immigrant women and some women and Muslim women, the religious values, seeing a male to examine them is a barrier. I mean,
There's a barrier, yes. Yeah, I can
that's
see
not,
that, right.
that's not any hidden information. And the data shows that, looking at studies on immigrant women. But for, and for a woman who's Black to come into me, I have to show her that I sincerely care about her. So I love what you're doing at Yale, and it's not unique to Yale, and it's not unique to teaching doctors.
Yes, I know. I've done the same thing at Quinnipiac, so I know it's not, it's what's going on right now. People seem to be searching for answers and how to close these gaps and get people healthy. Because quite frankly, I think it costs the medical community a lot more money in the long run when you have people who are not sick or do not go to seek, do not have regular care, who are not regularly under a doctor's care. So I think it ends up costing the medical community more money. People die needlessly. I think so. It's a big challenge, and you're right. We do need time. So some final words from you.
I want to thank you for this platform. I think we need to work at multiple levels in the community, educating providers, and I think we need a policy change in guidelines for when screening starts. I believe, I'm not an expert in prostate cancer, but I believe that men of Caribbean descent are allowed to have PSA screening for prostate cancer because they're at higher risk than white men. And if therefore we have a precedent that we should identify risk, women of Jewish Ashkenazic descent, men who are at increased risk of prostate cancer, Black women who are at increased risk of developing breast cancer young, and not only push to have the guidelines embrace those women, maybe start mammograms at 35, not maybe, we should start mammograms at 35 to capture a percentage of those 33% of women who develop breast cancer before the age of 50. But then we need to educate providers to order those screening mammograms. And I think that we can turn around. You asked me earlier, and I dodged this question. There's a 3 times increased mortality for Black women than white women. This is outrageous. And part of it is the biology of the disease, but I think a huge part is education and earlier detection. We know since the 1990s, mammograms save lives. Mortality from breast cancer is down 30% since the 1990s when we started mammograms. That should be for all women.